Hey, Michelle.
Hi, now you can probably hear me, huh?
Yes, I can hear you now.
How are you doing?
Doing well, doing well. Just
Excellent.
subbing in today for
I know.
Miss Merriweather.
Yes, that's
Merriweather.
right.
So
That's right. We expected you.
yes. So I will, I'll just remain off camera until someone asks me for
Yeah,
my
that sounds
opinion or
fine.
advice. My opinion or
That
advice.
sounds
But
fine.
I'm here. I'm here listening.
Okay,
So
very good.
all right, I'll be
Thank you.
following along. Thank you.
Okay, thanks. Hello, Venkat.
Hi, Misha. Good afternoon. How are you doing?
I'm doing well. How are you doing is the
Uh,
question.
yes, Misha. One more week, few more days hanging in there.
I
Thank
know.
you.
Good, good, good. All right. Hello, Sing. Okay.
I was on mute. Hi, how are
We
you?
know. I'm good. How are you today?
Well, doing well.
Good. Thank you for joining us the other day. Hi, Joy.
Hello, how are you?
Good. Thank you for jumping in. I think we had left you off today's invite, so I appreciate you jumping in.
Not a problem.
Hello, Dana. Dana, how was your trip? Or have you not gone yet?
I haven't gone yet. We're
Okay.
leaving Wednesday.
Oh, okay.
And
Everyone's
yeah.
everyone's going here and there. Some people are just back, some people are going.
Oh my goodness.
Hi, Nikki.
Hey,
Hi, everybody.
hello. Yeah.
Hi, Kat. Welcome.
Hello. Welcome.
Jane, I think we're getting some feedback from your, you might want to mute yourself if you're not talking. That's better. All right, we're gonna give it a few moments. We are, I know we're waiting on Laura Herrera Scott, Secretary Herrera Scott. And I don't see that Aika is on, or Board Member Crandon, or Maria. Oh, there's Maria. Hi, Maria. And Ben is not going to be here today. He's on vacation. Hello, Brad.
Good afternoon.
Once we get our chair, we'll be ready to go. And Amelia, if you can just pull the slides up so we know that they're functioning. You can present. I think the front page is just a cover welcome page anyhow. Beautiful, thank you. Do we have a cover one before that or not? Maybe
This is the first one, so I
It's the
think no
first one.
cover.
okay. Well, we can leave it there. That's fine. Hello, Aika. Welcome. All right, we're just waiting on the board chair and then we can get started.
Board chair is just joining now.
Ah, very good.
Michelle, do we have a quorum once the chair joins?
We do. We have a quorum once the chair joins. Board member Stefan is on vacation and I haven't seen board member Crandon join yet. Ah, okay. All right, so our chair is here, but can't turn on her camera or get off of mute. So maybe, or maybe if you dial in from your phone might work. Or go out and come back in. And just while we're waiting for the secretary, just reminders for the board, please keep your cameras on. And everyone keep your everything muted unless you're speaking. And then any presenters as you present, please come on. Can we unmute Laura? I don't think we can, Amelia, can we?
Think so. I just asked her to unmute.
I don't even see her. Is she on by phone? Okay, she'll hang up. And I don't even see her connected. Ah, there she is. And today is the board chair's first day back from vacation, well-deserved 2-week vacation. So I'm sure I hope her calmness of vacation is hanging around. These little things creep up on us.
Maybe she's in a different time zone.
Well, while we're waiting for her to connect, I can at least do an introduction. We have our newest board member with us today. Oh, hello, Board Member Crandon. I see you've joined. Thank you. We have our newest board member who's on with us today, Catherine Rogers, Kat. And Kat is a director of community health initiatives at Tidal Health in Salisbury, Maryland. She just has a wealth of experience that she's bringing to the exchange, both in public health, and she even was at the Worcester County Health Department in the Lower Shore when we started the Affordable Care Act. So I remember working with Kat way back when. She since then has really pursued her career in public health, and really just thrilled to pieces that we were able to have someone continue to represent the Eastern Shore. When Dr. Allen left, that was really important to us, and that she has such experience with the exchange and such experience in public health and the Affordable Care Act. So welcome, Kat. We're very happy to have you, and I don't know if you just want to say hello. Oh, and I see the board chair has joined us. So hello, Secretary. Welcome back from your vacation.
Thank you. Sorry, I'm so late. I couldn't get in, but a fourth time works. So
Good.
shall I get started?
Yes, please.
Did we want Kat to say a few words? I interrupted while you were introducing her.
Maybe we
Welcome,
should-
Kat.
I was just going to say thank you for the kind introduction. I'm really happy to be here and contribute and help serve in this capacity. So thank you very much.
Great.
Thank
Well,
you.
welcome to the board. So I'm going to officially open up the meeting. It is September 16th, and it's now 2:10. I'm sorry for wasting 10 minutes of everyone's time, but we'll officially open up the meeting and call it to order. And I'll start with approval of the April 19th minutes. Can I get a motion?
So moved.
Thank you, Dana. Second?
Second.
All in favor? Aye.
I have a comment before we take the vote.
Okay, go ahead, Sue.
So as a part of my report, if we go to the second page, the second line, it says the committee also discussed 4 requested contractor positions under the IDIQ delivery. And it really left the meat of that discussion. The issue over there was that these 4 IDIQ contracts were signed for a 3-year period. And we knew that our need was for a much smaller period. And we had a discussion at the Audit and Finance Committee and also at the board meeting that these can be canceled sooner for convenience of the government. And our discussion was that whenever you cancel a contract for the convenience of the government, there's a cost associated with it. And we were assured by the general counsel or by the council that in this case, there will not be any cost to be paid, except for maybe minor, like if they bought a laptop. So I think that was very critical because my understanding has been that often there are costs associated, especially if the vendors have engaged the resource for a longer period of time and they have to give them a separation clause or something. So I think I wanted that to be reflected here, which is what was presented, that there will not be any costs associated with early termination, which is what our need was.
So thank you for that, Singh. So Michelle or Cynthia, as a matter of process, do we have to go back to the recording to confirm what Singh is saying and then amend the minutes and then just take a vote on the August 19th minutes at the next board meeting?
I'm going to ask Blake to opine here because I think we've done it, a couple different ways. We've done it that way. We've also said, well, we've got it recorded now in this meeting. So Blake, can you weigh in on this?
Yeah, I mean, well, I would just say that I was present at the meeting where this was discussed. I was the attorney that advised on this issue, in fact, to the committee. And the board member's recollection is also my recollection of how the meeting went. But I would say that, yeah, we have a recording of it. We can certainly review it and revise, and then we could do a partial board minutes, or subject to revision, and do it at the next meeting, essentially. But I will just say that I was at that meeting and that was the meat of what was discussed.
Okay, so we can bring it back. I mean, if you want, we can either partially approve it or just pend it and we'll make the modification, we'll amend it, update it, and come back next month with 2 meeting minutes.
So I'm okay with partially approving it and then amending the meeting minutes at the next meeting to reflect Singh's comments. Do I need a motion to do that? Or can I just introduce the motion to partially approve? So 2 motions, one to partially approve and then amend at the next meeting and then to actually vote on approval of the minutes. Is that how that works?
I guess there's a few ways that it can be done. I'm just looking at the motions that we have presented for you to do the minutes, if this is a way to just work with what we have. I guess we haven't amended it yet. So I guess what we should do is we should move to defer the Board of Trustees minutes from this, just as presented. We should just defer them, and then next time we will approve them as amended, I guess.
Okay, great. So I move
we should yeah, sorry, excuse me. We should move to defer, yes.
Yes, so I'm going to make the motion. So I move to defer the Board of Trustees minutes from the August 19th meeting as presented until next meeting when they can be amended based on Singh's comment.
Second.
Any other questions or comments?
Does that
All
mean
in
that the previous motion has to be rescinded? Because we didn't have a vote on the previous motion.
I don't think we have-
Yeah, that's a good question. I guess I didn't quite catch. I thought there was discussion before she actually put the motion you actually put the motion and then you asked for discussion.
Well, we got a first and a second, and when we were moving to get quorum, that's when Singh brought up the question about the comment related to the contractual staff.
Okay, so that hasn't been voted on yet. So I guess, yeah, we should either rescind the previous motion and then put forward a new motion, or just
Okay,
formally vote on the old motion and then put forward a new motion.
so then we're gonna take two votes. One is I move to rescind the Board of Trustees approval of the minutes for August 19th. Can I get a second? All in favor? Aye. Cynthia, do you have I can't see everyone on the camera to make sure that everyone's voted and we have quorum?
And it's Amelia's filling in for Cynthia today, although it says Cynthia. So Amelia, were you able to record everyone's hand raised?
And I'm abstaining since I was not at the meeting, obviously.
Thanks. Yep, I was able to record.
And we have quorum?
We
We
do have
absolutely
quorum.
have quorum. Yep, everyone's here today.
Okay, great. So then the second motion is I move to defer the Board of Trustees minutes from the August 19th meeting as presented until next month. Can I get a second?
Second,
Any questions or comments? Okay, all in favor? Aye.
aye.
Any, Cynthia, Amelia, I can't see, so I'm gonna, any opposed?
I see no
So-
opposed.
Okay, so Amelia, you confirmed, there were all ayes, no. I don't know if I should ask if anyone abstained, because I didn't know how many, if everyone voted for yes.
I voted for yes.
Okay. No, I'm just asking Amelia. So Cynthia normally gives a report out saying that all are in favor so that I know.
Got it. Yep, all are in favor, confirming.
Okay, thank you. So the motion carries and we will defer the meeting approval of the August 19th minutes to next meeting. There is no one registered for public comment, so I will now turn it over to Michelle to give her executive director report.
Thank you. And I want to clarify one thing I just said. You asked if we had quorum, and I said, yes, everyone's here. And everyone's here but Ben. Ben is on vacation. So I just wanted to be clear in my statement. Thank you, everyone, for joining today. And we're so thrilled that Kat is here with us. So welcome, Kat, for your first meeting. We are at the federal level. We are in week 2 of Congress's 3-week September schedule. And of course, we're all hoping that they will get together and confirm some continued funding for the federal government beyond September 30th. As has been in the past, we are not aware of anything that would impact our work should the government shut down. So we're still in good shape. We are continuing to advocate with our federal delegation, with all national stakeholders, about the importance of the continuation for the expanded tax credits to continue under the Inflation Reduction Act, which are set to expire December 2025. We do know that if those are discontinued, we would see an impact to our enrollments for 2026. So we know how price sensitive health care is, and health plans in particular. So that's about the only thing really on the top of our agenda at the federal level right now. Those are the 2 biggies. But speaking of enrollments, our August data report is now available on marylandhbe.com. And this month highlights, again, our private plans are still well over 200,000. We're 217,692, 14% higher year over year. Our income-based Medicaid enrollment is at 1.2 million, a little over that, nearly back to our 2021 level following a year-long process to return to our pre-pandemic eligibility, putting in place our pre-pandemic eligibility rules for Medicaid. New enrollments to MHC, and these are not renewals, just new renewals or new enrollments continue to climb. We're up 35% of our total enrollment. Again, another all-time high. In the areas that we continue to focus on and make sure that we're getting our message out and getting people enrolled continues to prove successful. Our Black consumer enrollment is up 24%, Hispanic consumer enrollment up 23%, and our young adult enrollment up 46% year over year. Now, what's even more important about the young adult enrollments, those that receive subsidies, that enrollment is up 56% year over year. So we're really thrilled about that. And we do know that there will be some movement to continue that program and move it out of the pilot phase. So we're expecting that to come up in this session. Our special enrollments for enrollees with incomes less than 150% of federal poverty level in August 2024 nearly doubled what they were the prior August. So again, all measures are really, really good. We are right now laser focused on our 12th open enrollment. Hard to believe that this is number 12. But health plans and rates have been approved. You're going to hear more about them today. Our training materials updated and are being delivered. Our target marketing and outreach plans are underway, and our system updates are being finalized. Renewal notices will start to be prepared at the end of this month. Our plan shopping opens October 1st, and of course, open enrollment for the 2025 plan year starts on November 1st. And, you know, we talk a lot about why we do this and our mission to make sure everyone has health coverage. And it was just another report came out recently that just affirms what we're doing and why we're doing this. On June 1st, the American Surgeon published a paper on the impact of the Affordable Care Act on revascularization versus amputation in patients presenting with chronic limb-threatening conditions in Maryland. So this was specific to Maryland. And what they did is they compared the rates pre-Affordable Care Act and post-Affordable Care Act. What they found was that broadening the insurance affected limb loss in Maryland. Amputation rates dropped from 56% to 23% after ACA implementation, while the revascularization rates soared from 44 to 77%. They concluded that broader insurance coverage enabled more people to obtain basic routine care, which in turn led to better preventative care for people with diabetes. And this study confirms what we have been seeing in our reinsurance program, the state reinsurance program, where we've seen claim dollars declining for our number one condition, which is diabetes. And I would also suggest that the focus work that the Maryland Department of Health has done and our benefit designs and the work we've done in our plans have really helped get this care out to folks suffering from diabetes in Maryland. So it's a great study, and it just kind of recap for us, this is why we're here, this is what we're doing, making people healthier and driving down costs in Maryland. And I'll stop there.
Thank you, Michelle. Incredible work is all I can say, and the enrollment and just an example of what healthcare coverage means for people. So thank you for sharing that study. So next on the agenda, we're going to get a board committee report from the Standing Advisory Committee. Ika, you're on?
I am. Hi, everybody. I don't believe I gave an update last month, so I will cover a bit of July as well as September's meeting and sort of what we discussed. And we talked a bit about, we had the Prescription Drug Affordability Board come and talk a bit about prescription drug availability and cost reviews and upper payment limits. And then Betsy from MHBE discussed a bit and shared around the open enrollment consumer user experience key findings report, and kind of gave us sort of a bird's eye view into understanding sort of the real-time usage and behavior of the consumers. And then following that, sort of connected, Michelle talked a bit about the plan certification standards. And in the September meeting, Becca came to give a value plan preview for what the anticipated plan certification standards will be for 2026. But most of the meeting last week really was centered around maternal health and coverage for pregnancy and postpartum care. Pregnancy is among the top 5 most frequent hierarchical condition categories reported for a reinsurance population. And so we spent a lot of time discussing within MHBE's authority to address sort of maternal pregnancy, postpartum care. What are some things that we can kind of consider, especially around affordability, cost containment, and health equity? And then lastly, there was an interest in just having a presentation and hearing more about HRAs, noting that it, between providing support on tax implications and just supporting those choices to be a little bit clearer, and potentially having the marketplace be sort of a key communicator for that. So I'll pause there to see if folks have any questions and turn it back over to you.
Any questions? Okay, moving on to the annual compliance report. Scott?
Yes, thank you, Madam Secretary and members of the board. Happy to have the opportunity to present our annual report for compliance and privacy. Next slide, please. The 4 main topics that I'm going to discuss today include board oversight of compliance and privacy, initiatives that we're undertaking for our policy updates across the exchange, of course, our annual fraud, waste, and abuse report metrics, as well as our privacy program metrics, along with external audits and corrective actions and internal reviews. Next slide, please. Next slide. Thank you. All right, first is to discuss the board oversight of compliance and the compliance director's role in communication with the board. The director of compliance and privacy does have the ability to report directly to the audit and finance committee and does so on a quarterly basis. The exchange has an established protocol for escalation of significant compliance events. And we have in the past fiscal year updated our policy to formally outline the ability and the method by which the director of compliance, myself, would report independently to the board if and when necessary. And again, that is done through quarterly reporting to the Finance and Audit Committee, as well as our annual reporting, our department's annual reporting via this report to the Board of Trustees. And it also enables ad hoc reporting as necessary to the Board Finance and Audit Committee. And this is all to highlight the established independence of the role and the necessity of communications directly with the board if that is ever necessary. Next slide, please. Next, I'd like to cover our initiative on policy updates. So policies and procedures really serve as the cornerstone of a good compliance program, and having updated policies and detailed procedures helps MHBE to meet its objectives in a consistent manner while helping control identified risks. And so that's why we've undertaken this major initiative to get all of our policies up to date and fully revised to reflect our most recent not only policies, but the procedures by which we detail our methods to conform to those policies, adhere to those policies. So this formal process and revision process, which is led by compliance, was initiated in the beginning of FY24 and is projected to be completed by December 31st of this year. And this process involves identifying policies in need of review and update, establishing cross-functional area work groups to meet and update the policies, and discussing and finalizing policies through bi-monthly compliance committee meetings comprised of MHBE's senior leadership. And after review at the compliance committee, policies undergo a post-committee review and then go to our executive director for signature. And then those final executed policies are then saved in a location accessible to all employees and stakeholders and are disseminated via email with summaries to all stakeholders. And MHBE currently has 89 policies that govern our exchange processes. And while all are not due for update, I have provided a list of where we were at the end of FY24 with regard to our progress. Next slide, please. So this represents a snapshot. I'm not going to go through each and every one, but this just provides a snapshot of the progress made on those that were fully revised, executed, and posted, as well as those under final review prior to execution. And those represent policies that in the column to the right, those policies that have been reviewed by senior leadership at compliance committee and are just in the stages of finalization, legal review, and execution. And I will say, again, this report represents through June 30th. I will say that we have a total of 27 that are fully completed and executed to date instead of just the 12, and a total of 45 out of the 89, which are at or near completion. So we are making good progress in this initiative, and we'll be happy once we get our backlog cleared, because then we have a process going forward to maintain regular updates so that some of these policies don't fall out of date and that our procedures adapt with our innovations and our improvements. Next slide, please. This is the fraud, waste, and abuse report. Next slide. All right, a quick summary of our FWA allegations. On the left column, it represents those allegations that come in through our compliance hotline. I will say that most of these are consumer related complaints, and we investigate each and every one. Below the 15 number, you'll see that one was substantiated and forwarded to the Maryland Department of Health for investigation. One was unfounded and forwarded to MDH for system updates, and 13 of those 15 were found to be unsubstantiated and closed. To the right, you'll see the summary of our debarment and sanction screening. This is the Health and Human Services Office of the Inspector General, list of excluded individuals and entities. We do a monthly check of all of our employees, contractors, vendors, and carriers to ensure that none of them are on this exclusion list. And so that's something that we perform regularly. We have a process by which we clear everyone and escalate any discrepancies or possible matches and rule them out or escalate them as necessary. And happy to report that we have no excluded entities, nor did we find any excluded entities in FY24. Next slide, please. Next section is our privacy program metrics, our external audit summaries, corrective actions, and our internal reviews. Our privacy overview, I'd like to start with just some of our executed agreements. You can see we have 4 of them on the left there. These represent where we put in place privacy controls with stakeholder partners that would be handling our sensitive and private information, and in particular consumer PII. And so we have standardized adequate controls that we believe address and protect our privacy interests. They have reporting requirements for privacy incidents, and then they manage the obligations of our partners in the performance and safeguarding of that private information that we share with them. As far as assessments, we conduct an annual internal comprehensive assessment through our privacy impact assessment, as well as our MHBE self-assessment. These happen in June of each year. And one of them pertains to agency-wide PII management, and then MHBE covers all of that information that would be uploaded or stored on the cloud, and how those controls are in place, and an assessment of those across our various platforms where we store PII. And then as far as procedures, compliance, privacy, and privacy partner with cybersecurity to combine our trainings into a robust cross-functional training once a year that's required for all employees and contractors to complete. And we're very happy with that training and how it's evolved, and how we work with IT to make sure everybody takes that in a timely manner every year. Now down to our privacy numbers. Our total incidents for FY24 were 194, with 78 being misloads, and then 72 being producer errors. You will see an uptick over from FY23 to FY24. While I can't say the direct causation, I think there is correlation between the increased number of brokers working within our system and our exchange, and just the statistical increase that you'll naturally see with more brokers, particularly newer brokers, working out some of the challenges of getting familiar with our exchange protocols and protections. So again, we track these on a monthly, quarterly, and yearly basis, and so these are our numbers. We're not terribly concerned about this, because this correlates pretty directly with the increase in our broker amounts. Next slide, please. All right. This is a summary of our external audit timeline. I don't want to go too deeply into detail, but I'll highlight a couple of these that are important. They're all important, but I'll select a few to highlight them. So we have our improper payment pre-testing and assessment. This is done with CMS, and this is something that started this January, at the beginning of this year, largely coordinated with our IT department, and that is undergoing its first year of formal participation. The perm audit is perm audit is coordinated with Maryland Department of Health, which we work very closely with, and then report our findings and corrective actions, which are then escalated from MDH to CMS. DBM Red audit is an HR related audit. We have our IRS corrective action system security report audit, which is largely coordinated by our IT department. The next 3 items on here are our independent external audit for financial, independent external programmatic audit, and then the CMS smart audit. These are all essentially the financial audit and programmatic audit are essentially contributions and requirements that go into the smart submission, which is an annual review by CMS of our financial controls and our programmatic controls. I'm happy to report that our financial audit was completely clear this year with no findings. Our independent external audit yielded one result, which was something that we are undergoing corrective action. It had a limited impact on the number of our consumers, but nevertheless, we have some corrections to make to come into compliance as a result of that finding. And then CMS, we will usually hear around this time of year regarding their findings and recommendations as a result of their examination of not only the 2 external audits we provide to them, but also supplemental questionnaires and documents that we provide to them. So they evaluate that and get back to us. And then finally, our Office of Legislative Audits. This is, I'm confident to say, is officially nearing completion. We have our discussion notes. We've had our exit conference meeting with OLA. The subject matter is considered confidential until such time that OLA publishes its official report. So I can't discuss any particular details just yet. I will say that there were no findings that were particularly surprising, which is, I think, always a good thing. But we definitely have some process controls and lessons that we can incorporate into not only our policies, but our procedures going forward to help us be more compliant. And more to come as that report is issued. We can, of course, discuss this more in committee and with the full board as necessary. Next slide, please. Excuse me. So this is these first 3 audit findings are I think I essentially addressed those in the previous slide. Our independent audit with the 1 corrective action plan underway, our DBM red audit, which was the HR related audit with corrective action underway, and then our perm audit in concert with MDH, where corrective actions have been established, passed on to MDH and approved by CMS. Moving on to our internal reviews. Our internal reviews were paused for FY24 due to intensive commitment with OLA, as well as some departmental resource issues we were facing at the time. But we are resuming those annual internal reviews very shortly in September, later part of this month. And then that will coincide with, of course, OLA concluding its audit and making way for us to conduct those in a comprehensive and proper manner. Next slide, please. So this time I'd like to open it up to any questions, comments, or clarifications that any members of the board have.
I have a question.
Yes.
You had mentioned that there was 1 complaint that was forwarded to the Department of Health. I wonder if you could just give us an idea what the general complaint, what the subject of the general complaint was.
Yes, thank you for that question, Board Member Wexler. So that particular complaint was from a consumer, and I believe, if I don't have the actual log item, but from what I recall, that was an allegation that an individual was using another address to falsely claim that they were a Maryland resident. Now, oftentimes we'll see these kind of fraud allegations, and more often than not, we'll rule them out by a failure to update the information, or more often than not, just a mistake within the system that is treated more as a privacy incident. But sometimes addresses get miskeyed, and and notices are sent to the wrong place. And rather than fraud, it appears to be fraud when you receive that notice, but it turns out that it was in fact a mistake. I believe this particular instance was not one that we could rule out as a mistake or otherwise, so it was forwarded on to MDH.
Thank you.
So
Certainly.
Scott, this is Laura. I want to build on that because I was going to ask the same question, Dana. Where in MDH did you send it to, the OIG, or who did you send it to within MDH? And then do they close the loop with you on the outcomes of the things that you're referring to the department?
So it would have been forwarded to, it was forwarded to the OIG.
Okay.
So that is where that we forward them to. And as far as closing the loop, we have not closed the loop on that particular complaint to date.
Okay, and just for everyone's benefit, I think in 2022, I'm not sure what year, but the OIG is an independent body now. It's not technically part of the department anymore. The OIG is appointed by the governor, the controller, and I think the attorney general, but just want to clarify that. That's why I was asking you, where was it referred to in the department?
Certainly.
Any other questions for Scott? Okay, thank you.
Thank you.
Next, we're going to get a 2025 health plan landscape update. Nicole, are you on?
Yep, I am on. Good afternoon, everyone. My name is Nicole Edge, and I am the program manager for the plan management department at MHBE. And just going to go through the plan landscape for 2025, both medical and dental plans. Next slide. All right, so one major difference from 2024 is that we have onboarded or are in the process of onboarding a new carrier. So WellPoint is a new entrant into the marketplace. And if you notice here on the map, WellPoint is one of the 5 or one of the 4 now carriers that we have that's statewide. So in total, we have 5 participating carriers on the medical side of things. And 4 of them participate statewide or offer plans statewide. WellPoint is one of them. And Kaiser continues to offer partial county. And so they have service areas, partial service areas in Charles, Calvert, and Frederick counties as displayed on the map in the darker blue. Next slide. So another difference that you'll see here, if you review and go through some of the plan offerings for 2024 and 2025 in the metal levels, you'll notice that there is 1 less in the silver metal level from Kaiser, United, and Aetna, and also a reduction in gold from Kaiser and United. So this is because we entered a requirement for 2025 plans that carriers can offer no more than 3 plans per metal level. And this was a recommendation from our 2022 affordability work group. And it was to address the choice overload that consumers would have in plan shopping, making sure that consumers can make more informed decisions with a lot less being bombarded with a lot less. And so we wanted to make sure we had quality plans that address some of the areas that we are, striving to look for when we are incorporating like the value plan standards. And so one of the things that came out of that work group, one of the recommendations was to reduce metal level offerings. And so we did do that. So you'll see that reduction here in both the silver and gold. You'll also see the addition of course, the WellPoint plans. So in total, we have 49 plans being offered in 2025. And that's just a little up from 2024. And again, that addition of WellPoint. Next slide. And then just 2024, 2025, just an overview of what the AV looks like from 2024 to 2025. No huge difference here. Of course, the AVs are set 60% at bronze, 70% at silver, 80% at gold. And of course, those there is some variation that is allowed on the lower and upper range for those AVs, but all of the plans that are being offered do meet those AV values that are required.
Nicole, could you just talk a little bit about what AV is? Maybe not everyone on the call knows what an AV is.
Sure, absolutely. So AV is the actuarial value of the plan. It really just depicts what, how generous the plan is and its benefits and services that it offers. And those values are set each year. And so 60, 70, and 80 for the bronze, silver, and gold respectively remain what those actuarial values are. And then, like I said, carriers are allowed to have some de minimis, so they are allowed like 2 percentage points under, 2 percentage points over. And a bronze, I think it's a little more generous on the upper side for like the expanded bronze of about 4%. And so that's what we're looking at. We're looking at those actuarial values that come in when carriers submit plans. We're looking to make sure that they're meeting that actuarial value and that we can explain to consumers with that AV how generous the plans are. So how much that carrier or that plan percentage pays, the carrier pays versus what the consumer will pay. Any questions on the AV from anyone?
I just have a quick question. So the
Sure.
value has nothing to do with the membership in that picks that plan, just on the plan itself.
Right, just on the plan itself.
Okay.
Any other questions about that AV?
Just another way to look at it. So if you have a gold plan, you would expect on every dollar, 80% would be paid by the carrier and 20% by the consumer, but that would be for out-of-pocket
Out of
costs.
pocket, yes.
Right, but
Oh.
but when I hear that, right, especially when you look at the AVs on the bronze plan, I start thinking about, you know, deferred care, things like that, because the delta is so big. And I don't know what the outcomes look like compared to the bronze and the gold as far as utilization and healthcare outcomes. So that's why I was asking on the person versus the plan.
Got it. All right, next slide. Go next slide. So there's no change in our offerings for our dental space. We have the same participating carriers, Care First, Delta Dental, which they have 2 licenses. So one that offers their HMO product, one that offers their PPO product, and then Dominion Delta also has HMO and PPO products underneath of the same license of Dominion. And they are all offering the same amount of plans that they offered last year, and the same in tier, low tier, and high tier. So we don't have any change from our 2024, 2025 plans. Oh, no, we do have one PPL, and that is from our Alpha, which is the license underneath the Dominion. So, any questions on the dental landscape for 2025? All right, and any additional questions on the plan landscape for 2025?
One other item you might want to just mention is the vision plans. We don't approve those plans, if you want to speak to that, because that is an offering on the exchange.
Sure, yeah. So we do have standalone vision, and right now we have VSP as our participating carrier with vision. And so while we don't offer enrollment through Maryland Health Connection, so you can't actually complete an enrollment, we do offer just like a handoff link. And so we have a space where consumers can go, they can click that link and they are taken or redirected to VSP and are able to enroll in that directly. And that is a year-round product offering that they have. They have several products that they offer. And we just did an update on the enrollment. Enrollment numbers actually are really good. I don't have them offhand. Sorry that I don't have them offhand, but we do have a lot of folks that actually took advantage of a higher enrollment than we actually anticipated for VSP. So we are very excited to have them back for 2025. And offer some vision plans for consumers. It seems to be a pretty popular product, so we're hoping that enrollment will grow in that space as well.
And Nicole and Michelle, why isn't that something that the board evaluates, monitors the way you do health and dental?
So there are, different rules according to the ACA of what we can do and how we offer them. And vision is an option we can offer but it's not required that we have to certify them or bring them on board, I believe, but I could be Brad or Nicole, if I'm speaking out of line, correct me, please.
So we don't certify the vision plans in the same way that we certify our medical plans and dental plans. So we don't certify them. We do have conversations about some of the requirements that we have and the things that we want to see with VSP, and any addition to that vision plan space, we'll have those same conversations. So we do have those internal requirements that we want them to meet. They aren't as robust as the requirements that we have, again, for our medical and dental carriers, but we do have that there, but not as much really authority in that certification space.
Any other questions? Okay, thank you, Nicole.
All right, thank you.
I have a
Next one.
question or
Go ahead.
comment and question. Sorry. First thing is when I joined the board, we had I'm not sure exactly how many carriers, but I think it's more than double now. So I wanted to give kudos to the staff for going out there, finding more carriers, and hopefully, of course, to bring the, get competition there and bringing prices down and giving consumers great choices. Now, giving all that, is there any way that the exchange or maybe one of your contractors could tease out how much the competition may have decreased rates and increased enrollment? I know you can do that statistically. I just don't know if you guys can find a way to do that. Thank you. And it's great if you could.
I think that's definitely something we can look into. We might need a little more time. I know Aetna has just completed their first year within the exchange. WellPoint is onboarding now. 2023, 2 or 3, I believe we welcome UHC back in. So I think we can start to look at those numbers and have some conversations and kind of see year over year what that looks like, but something we can definitely take back.
And next on the agenda is Brad Bobin from the MIA, who's going to talk about rates. So he may have some comments to share on that as well.
Thanks, Michelle. All right, next slide, please. All right, in general, the MIA is charged to make sure that rates are not excessive, inadequate, or unfairly discriminatory, and they must be reasonable in relationship to benefits. Otherwise, the commissioner shall disapprove or modify a proposed premium rate filing. So for our ACA filings, we began the process by looking at 2023 experience data. The first step was to compare that 2023 data to past years and compare that 2023 data to what the carriers were previously projecting when they set 2023 rates. And that first step, we're trying to understand any deviation from expectations or any larger year-over-year movements in claims. And then after we review that initial experience, then we review the assumptions that project that experience from 2023 to the 2025 projection period. We look at these assumptions both individually and make sure each one makes sense in isolation and then also in aggregate. And that's really important as well. So we're looking at all these assumptions as they link together and making sure that in aggregate they are also reasonable. Key assumptions that go into the ACA rate filings are claims trend, both cost and utilization by different service categories. Morbidity, which is basically the relative health status of the pool, operating expenses, profit margin / contribution reserve, risk adjustment transfers, reinsurance recoveries under the state 1332 waiver, and finally this enrollment was the impact of the Medicaid unwinding on enrollment and morbidity was another key assumption. So all of our rate filings were submitted back on May 20th, and we just approved them a couple weeks ago on September 5th. Next slide, please. So this is a summary of what we've approved. If you look on the right side, the numbers in yellow show that initially back in May, the carriers filed for a 6.7% increase, and what we ended up approving was a 6.2% increase. And so by carrier, you can see that there's variation, and then that variation kind of narrowed. That when we push back on carriers, we push back more on the higher increases. So there's double-digit increases that were initially proposed for Care First PPO and for Aetna. Those both came down to single-digit increases in the 8.5% to 9% range. The one increase that came up from when we initially got the proposal was Care First Blue Choice, came up from 4.7% to 5.1%. That movement was due to risk adjustment. Care First Blue Choice has historically been a risk adjustment payer. So like Kaiser and like Optimum Choice, they pay into the program and the PPO entity collects the money. But in 2023, they switched to being a receiver. Because as they're shrinking in their size, they're becoming riskier in relationship to the rest of the pool. And so when 2023 actuals came in, they weren't receiving as much risk adjustment as they were expecting. And so they made an adjustment, and that's what drove that change there. Another thing I want to point out on this tab is that on the left, we've got enrollment, and that as of July 31st, we've got an enrollment of almost 271,000 total on and off exchange enrollees. That's up almost 18% year over year. Michelle, I think you said it was 14% year over year on exchange. So the off exchange is doing even better than the on exchange enrollment wise. And you can see the details that the Optimum Choice, the United entity, is really growing hugely in enrollment. They grew from 23,000 as of July 31st of last year to over 64,000 as of July 31st of this year. That's a 175% increase. And that's driven by, they've priced themselves very competitively. And to answer the question of what percentage decrease is due to competition, I don't have that at the top of my head, but United has come in and within the second year they were the second lowest cost silver plan, and they've been the second lowest cost silver plan since. And so they are definitely helping drive the marketplace down. And so and their enrollment is showing the dividends of that, because this is a very price sensitive market, and so there's been a lot of movement from both Kaiser and from Blue Choice into Optimum Choice. Next slide, please.
I had a question, if I may.
Sure.
We can go back to the slide. So when I look at the increases, fiscal 22, 2.1%, 23, 6.8%, and last year 4.7%. So even though we had 6.2% for this year, isn't that a significant increase? And not only looking at the percentage itself, but looking at the absolute number of members. We had 229,000 last year, and now 270,000 members. So 6.2% with 50,000 more members. Aren't those increases significant?
I mean, the average increase that was requested nationwide was 7%. So this is below the national average. And as I'm going to show on, I think, the next slide, we're starting off at the absolute cheapest in the country for bronze and gold, and so it's 6.2% on top of an absolute dollar amount that is the lowest in the country. And so I would not characterize this as a significant increase. No, this is a trend level increase that is slightly below average, and not significantly high.
The other reason I say, I understand that inflation was high, last 3 years, but now that inflation is coming down, from inflation of what, 17, 18% down to 2.5%. At that time, this to be going up almost 50% more than last year, 4.7% versus 6.2%. That's the other reason it appeared very high to me.
I understand that it's higher than last year, but I still would not characterize this as high, just given that it is statistically below average of what's being requested nationwide, and we're starting out at the lowest. I think it's difficult to characterize this as a high increase. If we could go to the next slide, it'll show, what I'm talking about. And so for the premium for an age 40-year-old weighted by zip code, this is from the the Kaiser Family Foundation. On bronze, Maryland is the lowest in the country at $256. And so the average in the US is $364. So right now we're 30% below average in the country. And so if you bump that 256 up by 6%, that would bring you up to $271. And it would bring us from the lowest to the second lowest. But our average, but that's where we are. So we are towards the bottom of the entire country, and we might move to the second lowest on that bronze plan. And a similar story on gold, and you can see on silver we're the third cheapest plan, but once again we're 27% below the U.S. average, and so the fact that our increase is still below the U.S. average, we're still widening that gap between the U.S. and the rest of the country. Next slide, please. So this goes into the trend that is the driver of the increase, and it goes into it by different service categories. And so the service categories that are required in the ACA rate filings are listed on the left there: inpatient hospital, outpatient hospital, professional, other medical, which is things like ambulances, home health, dental, vision, things that don't fit into these main service categories, DME, prosthetics, and then capitations, which are very small, and then prescription drugs. So you can see, the largest part of total claims is hospital combined. If you add inpatient and outpatient hospital together, you've got 37% of claims. And you can say that the trend that carriers are using on average is 4.3%, which is right in line with the HSCRC update factor. The HSCRC update factor was a 1.045 update factor, and what the carriers used in their filing was a 1.043. But then you can see for other service categories, there's higher trend values. For professional has a cost trend of 4.4% and a utilization trend of 3.9%. And so that combines to a total of an 8.5% cost trend on professional. So that's doctors, physicians, nurse practitioners, professionals of all sorts outside of the hospital setting. That is a lagging indicator to normal inflation as well. Generally, these professional contracts last several years, and so it's generally a lagging indicator. After general inflation comes, medical inflation kind of follows, and so that double-digit inflation that we saw a couple years ago, I would say, is just starting to show up in trends, now this year. And then we got prescription drug running at a 10.3% trend, double-digit trend. And that's 5.5% on cost and 4.5% on utilization. So these are the major service categories driving the cost, and we want to dig more into what is driving these, but at the end of the day, we can look at the claims trends, we can graph them out, and we can see that they are going up at a rate that is above general inflation right now, after 4 or 5 years of below general inflation. Next tab, please. So this tab, I wanted to show the variation by carrier of claims costs. You know, this is how the market snapshot in 2023 looks like. And so on the left, you've got the 5 legal entities that participated in the market. You've got CareFirst has 3 legal entities. CareFirst is Blue Choice, and then CFMI and GHMSI are the 2 CareFirst PPOs. You have the total allowed claims, almost $1.8 billion in allowed claims. You've got the total member months, and you can divide the claims by the member months to get the total claims PMPM. So in this market, we had an average claims PMPM of $654. And that's raw claims, that's total claims between both the carrier and the member before any cost sharing is applied. So this is the total amount that the providers are receiving. But you can see there's a big amount of variation. That, you know, the lowest PMPM is Optimum Choice at the top at 420. You know, that's 35% below average. And then the highest is GHMSI at 1650, which is, you know, 230% of average. So then you have risk adjustment, which is the key program to the federal program to help even this out and transfer money between those with lower cost members to those with higher cost members. And so in this column, a negative number means they're transferring out. So Optimum Choice and Kaiser are transferring into the program, and Blue Choice, CFMI, and GHSI are receiving money from the program. And so this is a $0 program, a zero-sum game. There's no money being pumped in from outside. But you can see that this kind of narrows the gap between the PMPMs between the different carriers. And this helps, you know, even out the premiums in the marketplace as well. And so with risk adjustment, you know, you got a range of 497 to 1181. And then you layer on reinsurance on the far right. And reinsurance is not a zero-sum game. Reinsurance is coming from the state money. So there are $567 million in reinsurance that is being taken out of this pool. That's about 31% of total claims. And so you can see the reinsurance by carrier, and then after the reinsurance is applied, you can see that, you know, the total PMPM for the whole pool lowers from 654 to 452. So that's the power of reinsurance and why it's keeping our premium so low. And then you can see that it also narrows things out even more between the carriers. So at the end of the day, you've got a range from lowest to highest is much closer than before the risk adjustment and reinsurance are applied. So any questions about this? I know this is kind of a dense slide. All right, thanks. Next slide then. So this is a snapshot of the MLR history in the individual market. I presented on this last year up through 2021. And we've got 2022 numbers now to report. As a reminder, you know, there were no rebates in the entire individual market from 2011 to 2018. The individual market started out really underpriced and a lot of financial problems. Carriers were losing lots of money. There was nobody coming close to giving out a rebate. Then in 2019, we implemented our reinsurance program. And it worked very well. It worked better than the carriers thought, and lowered claims more immediately. You know, the carriers were projecting that claims were going to come down over the course of 2 or 3 years, but they came down drastically in year 1. And so in 2019, carriers owed rebates because of that, because they were over projecting because of reinsurance. And then in 2020, we had COVID. And COVID also decreased claims somewhat counterintuitively, but because there were shutdowns and because all non-elective surgical procedures at hospitals were canceled during the second quarter of 2020, carriers owed rebates again in 2020 because they unexpectedly had lower than expected claims. And then, you know, the rebates in 2021 are because of the 3-year nature of this calculation. So I'll show that on the next slide. But the MLR rebate, you know, the standard is 80%. You have to keep your loss ratio over 80%. But you only owe a rebate if the 3-year rolling average goes below 80%. And so the 2021 rebates are from 2019 and 2020 still being so low. And then you can see in 2022, rebates fall drastically. That, you know, in 2021, it was $45 million, 4.1% of total premium. And in 2022, it falls down to 2.3 million, which is 0.2% of total market premium. And the main rebate in 2022 is Optimum Choice, the brand new entrant, who basically, you know, attracted very extremely healthy members, healthier than they were expecting. And so that's the driver of the rebate there. Next slide. So this shows the details between those rebates for 2022. So you can see in the 2020 column that there were some very low loss ratios for Care First. That's that COVID year. But then you can see that 2021 and 2022, the loss ratios came up significantly for those Care First entities. And that in 2023, the 2022, the 3-year average was, you know, just barely below 80% for the Care First PPOs. There's a credibility adjustment. So even though the Care First PPO CFMI was technically slightly below before the credibility adjustment, they were deemed not credible enough to owe a rebate. And so there was no rebate owed there. The GHMSI came in at 78.1, but they had a 1.7% credibility adjustment. So they only owed a 0.2% rebate after their credibility adjustment. And then same thing with the Optimum Choice. They got a credibility adjustment. They came in all the way down to 73.3%, but they got a 2.7% credibility adjustment, and they ended up owing 4% of their premium back in rebates.
Brad, can you talk a little bit about what is what are the criteria for a credibility adjustment?
Sure. The criteria for credibility adjustment is all driven by the number of member months. I don't know the specific criteria off the top of my head, what member months translate to what adjustment, but I mean, the basic theory behind it is that the smaller you are, the more likely that you are to have variation from the mean that's due to just statistical variation and not due to underpricing.
Okay.
And you don't want to penalize a small carrier for that. And so you get this credibility adjustment to not over penalize small carriers for normal statistical variation, because, you know, no matter how perfectly you price, you're expected to have variation from the mean. And the smaller you are statistically, the bigger the variation becomes. So the very large carriers like Care First, Blue Choice have, you know, no credibility adjustment because, you know, there's very little variation when you take a sample there. But you know, that's the basic theory behind it. All right, next slide, please. So this slide compares the value plan premiums for the 5 different carriers that are going to be in the market in 2025 for 3 different ages: age 21, age 40, age 60. You can see that, you know, there's a pretty competitive market. The Care First PPO is priced significantly higher than the other companies. Even after risk adjustment, it still has the riskier population. But you can see that the HMO population, the 4 HMO companies are all clustered, you know, pretty low. And you know, OCI is the cheapest. OCI being optimum choice is the cheapest on every metal level this year. But you know, as far as who's the second cheapest, that varies. There's different carriers on different metal levels. But you know, this is all same plans, you know, the value plans for each metal level. Next slide, please.
Brad, just a reminder for those watching that the value plans are our standardized plans. So each carrier has to offer the exact same benefit design.
Yeah, thank you. Thank you for that clarification. This is a similar chart. This just shows the cheapest bronze for each carrier. And I guess actually that 256 on that page I had previously, that's going up to 261. That's that optimum choice on the second to last line. So you know that's our cheapest bronze for an age 40-year-old is only going up 2%. So it's going up below average. You know, $5 PM, but you know, likely we're still going to be the cheapest bronze next year. Next slide, please. This is a similar chart showing the cheapest silver for each metal level. I mean, for each carrier. Want to have a note that on optimum choice that they're introducing a new off-exchange silver that's 11.6% lower than their on-exchange silver. That's not really, you know, nobody is going to be auto-renewed into that, but you know, we're showing the cheapest one for each year. So, you know, just as a note, you know, several carriers have off-exchange only plans, on silver particularly. Having an off-exchange plan on silver allows it not to have the CSR load. The CSR load covers the cost share reduction costs. Cost share reductions are only available on exchange. And so we only make carriers build in the CSR cost on exchange. So carriers also can have off-exchange silver plans that are offered cheaper. So that is why this change is shown up here. Care First and Kaiser already had these off-exchange silver plans. So they're not showing a negative. And then next slide, please. And then this shows what's going on with our cheapest gold plans. And once again, you can see optimum choice at the bottom there. You know, their cheapest gold plan is only going up 1.2%. So our cheapest option for an age 40-year-old is going to stay at $340 next year. And so you know there is a wide range of variation, but you know at the bottom of the range, you know I think we're going to remain amongst the lowest in the country. Next slide, please. All right, so this shows what was approved for dental. Originally, we got a request for a 2.4% increase on average. What we ended up approving was a 0.3% increase. And the big difference was what we did with Delta Dental. Delta Dental came in asking for a double-digit 18% increase, and we ended up approving a little over half of that. We approved a 9.7% increase for Delta. And that brought that average down from 2.4 to 0.3%. But you can see that, but you know, that average has Care First decreasing their rates and the other companies increasing their rates. So you know that there is a range, just like there was on medical, but this range, unlike medical, includes a significant number of people getting a rate decrease. And I will note that enrollment for dental, unlike enrollment on medical, seems to kind of have peaked. This is the second year in a row where it's basically been flat when we poll the carriers about the on and off exchange dental. But it's flat at a very high number compared to, you know, where it was 4 or 5 years ago. but yeah, it's, you know, hanging steady at 96,000 or so as far as the enrollment goes.
And one other comment, if I can just interject on that, Brad, is that Medicaid did incorporate adult dental into the Medicaid program. And so we actually had expected a more significant drop than what we saw. So we're really happy that, you know, it's still up there, albeit down.
Great. Yeah, thank you. Next slide, please. So this shows the sample premiums for the most popular plan for each of the 5 dental carriers, both last year and then 2025 and the change. And so you can see CareFirst is decreasing, the other companies are increasing. In general, the PMPMs are a lot lower than the medical PMPMs. But you know, yeah. Next slide, please. Okay, these numbers might be a little hard to read. So in small group, what was originally filed back in May was a 6.1% increase, which is that first purple number. What we ended up approving was a 4.5% average increase. So that, you know, the increase came down by about 1.6%. You can see the increases vary by quarter. For first and second quarter, the increases are averaging 3.2 and 2.4%. And then they go up to 5% as of third quarter and fourth quarter. The reason for that behavior are mid-year decreases that were put in last year. And so basically the third quarter people already got those decreases, but the first quarter and second quarter people haven't gotten them, and so they're going to get that mid-year decrease on top of the increase that's being filed. So that explains the pattern. And this is the third year in a row where we've had multiple carriers file decreases mid-year. So you know, we're trying to push them down more during the rate filing cycle to avoid those mid-year decreases. 4.5% is below trend. The average trend in small group is 7.5%, higher than the individual trend. So you know, the below average trend is increase is attributable to favorable experience in the experience period. You know, that starting point in that 2023 experience period. Claims in general in the small group market came in better than had been expected, and that's driving the below average trend increase. And then, you know, I'll comment, you know, enrollment is down about 5%, to down to 227,000. This continues several years of declining enrollment, which we don't like to see. But you know, it's not increasing in pace. At least it's a steady decline. But we'd like to see this reverse. You know, this is the first year now where the individual market is now considerably bigger than the small group market with the increase in individual and then decrease in small group. They had been comparable in size. So we'd like to see that reverse if possible. Next slide, please. And this is just some sample small group premiums. Same age, 40-year-old in a Baltimore metro region. There are more choices in small group than in individual. You can see a lot of EPOs and PPOs that are not available in individual. And final slide, please. And this is the same thing, which is sample gold premiums instead of silver premiums. Is there any questions?
Thank you, Brad. Any questions for Brad?
So I had just a general question. You know, with 200,000 some subscribers. Maryland insurance uninsured rate down significantly over the years. Having spent about billions of dollars since the exchange came into existence, much better care available to Marylanders, access to private doctors, all of those good things. Are Marylanders healthier today than they were 10 years ago? Do we know that?
I mean, that's not within the scope of my healthcare rate review. I don't know. I mean, I think it depends on what metric you're looking at. But I can't speak to general health of Marylanders.
Anyone? Maybe we should spend some time sometimes in the future to say, how have we contributed, other than billions of dollars, how have we contributed to the health of Marylanders? You know, are they living longer? Are they healthier? I think we should at some point think about it and try to answer that question. I'm sure there are ways we can define
Sing, the only thing I would say is, remember, COVID was the wild card. And so it really changed. If you do a look back in that 10-year period, there's 3 years at least from 20 to 21 where people weren't getting care because the delivery system shut down, except for you have COVID. And then we had delayed access to care. So we didn't really start to see the pickup in all that delayed care until late 21 going into 22, and quite frankly going into 23. And so the last 4 years for sure have been volatile at best. And then when you throw in opioids and you throw in a few other things such as gun violence, life expectancy overall has gone down. So it would be really hard to do the kind of thing that you're saying right now because of things outside. We had a pandemic for one, but then things that happen outside the delivery system. You'd want to chunk it out to specific cohorts if you wanted to do it that way. And you'd have to probably look at pre and post COVID as an example.
I agree. But any
And
which
then
way we
also
slice.
Go ahead.
Sorry, go ahead.
No. Just we have geographic variation on access too. So, yeah.
Okay.
Sorry to digress. Thank you, Brad. Any other questions for Brad?
Thank you.
Okay, next we'll turn it over to Tracy and to Venkat to go over the AWS option year 1 and the AWS not to exceed.
Good afternoon, Madam Chair, members of the board. I'm joined by our procurement manager, Tracy Gamble. Before we go into the procurement details, I would like to give a brief overview of what is Amazon Web Services for the exchange. And at the outset, I would like to make the difference between this product we are talking about from what we have on the MT Think platform, which is another AWS-based platform. This is the AWS that MHBE hosts for hosting variety of applications. To start with, our MarylandHBE.com stakeholder site is hosted on this AWS platform. And we have our current version of small business web and mobile apps there, and our very innovative Broker Connect product that's also on this platform, and our live agent chat that is supporting our consumers, connecting with the call center, and our consumer portal is also on this platform. And our internal WordPress site, which is our internal exchange site, that's on this platform as well. In the last couple of years, we had built, as you know, the dashboard, enrollment dashboard on this platform as well. And most of the innovative technologies, any proof of concept type work, we are performing on this platform as well. That includes the robotic process automation that we currently use to automate Medicaid document verification process as well. And as the board may be aware of, we are in the process of migrating several, actually 9 lower environments. Lower environments meaning the development, testing, and those kind of proof of concept kind of environments from MD Think platform onto the MHBE AWS platform to bring more efficiency to what we do. In our FY25 IT strategy, our plan is to migrate 9 lower environments. I'm very happy to report that we've already done 3, which can be sunset this month, and another 3 early October, and then the last 3 by December of this year. And when I see when we sunset from MD Think, that means the cost would be basically net neutral as a combined IT software budget cost. And we're also building a capability for the exchange disaster recovery and business continuity. And our plan is to go live with that in March of 2025. Next slide, please. So as I noted, in the last 2 calendar years, 2023 and 2024, and upcoming 2025, this is our progression. Over the years, we have expanded this platform for a variety of reasons in terms of bringing more efficiency into our operations and also to reduce the risk of over dependence on everything on one platform. We don't want to have all the eggs in one basket on everything. So we had adopted this strategy over the years. And in 2024, like I said, the 9 lower environments will be migrated, and we will be also building proof of concept environments. And early 2025, we'll build disaster recovery. And we are already in the process of implementing, expanding our business intelligence capabilities, which would give our stakeholders to look into consumer data at a granular level to do policy, discovery policy decisions and policy formulation, etc. And we are also, in 2025, we will be building a microservices architecture for the exchange, which would potentially define the exchange technology architecture for the next 5 to 8 years. And we are also working on the early stages of Kubernetes, which is an automation deployment process implementation as well. And all of these initiatives have been vetted with CMS, and we are part of our IAPD and part of our IT strategy as well. So I'll stop here, pause here to give a chance for any questions on the platform before I hand it over to Tracy for providing procurement update.
Thank you,
Right,
Venkat.
Tracy, please take it away.
Okay, good afternoon, everyone. If we could go to the next slide. So the procurement summary for this particular request. Initially, this request was before the board on October 17th, 2022 for the actual 2-year award. We're coming today to ask for your approval to exercise the option year, which consists of November 1st, 2024 to October 31st, 2025. Initially, we did this procurement based upon a request for quote through the GSA Schedule 70, and the successful vendor was A&T Systems Incorporated. The annual cost, it varies upon utilization, and as you can see here in FY23, we actually spent $382,037.55, and in FY24, we actually spent $555,965.29. And we're projecting in FY25 to spend $1.5 million. Next slide. So in FY25, we have it broken down. The product is Amazon Web Services, and there is a 75% federal split of $990,000. And then there's also a state split of $510,000, and for the total cost of the $1.5 million. Next slide. Are there any questions?
I have one, Tracy. I have 2 actually. So or maybe this is for you, Venkat, the 1.5, the increase in cost, those are for all the new things that you've laid out in FY25? when you had 23, 24, and 25, when you were describing the activities that were happening with AWS, that's what's making up the big jump in costs?
Yes, Secretary. So we are migrating the lower environments to MHBE's platform and also building a huge disaster recovery capability, and that's the bulk of the cost. And unfortunately, the cloud services cost, as you may know, it's a 20% jump between the last few years. That's an unbelievable amount of jump. But overall, net within the IT budget, and we expect to contain within the IT budget. For FY24 and FY25, we don't anticipate cost increase, specific additional budget for this initiative.
So, and you have the 510,000 general fund match that you need for the option year 1?
We do not need additional funding, Secretary. This will be within the approved FY25 cost for IT.
Are there any questions?
Singh has his hand raised.
So, Venkat, the 1.5 million, which is, compared with the 500 some thousand the year before, you said that it's a combination of some other things that are being combined into that. So if we look at all of those combined things into last year versus this year, how much is the difference between the two?
Yeah, that's a great question, Singh. In fact, in FY24, we came to the board and requesting a total NTE of $2 million for this platform to contain all these products and also the disaster recovery. Obviously, we have been working with MD Think to migrate and work on the disaster recovery, which didn't happen as per our original schedule. So to answer your question, our FY26 budget, let's say for the AWS ecosystem, would be around $2 million. And our goal is to still contain within the cost savings we would have on migrating stuff from MD Think, as well as efficiencies that we would achieve within the IT budget itself.
Thank you. That helps. Thank you.
Any other questions? So I'm going to put 2 motions forward. The first is I move to approve to exercise option year 1 from November 2024 to October 2025 to procure Amazon Web Services subscription from A&T Systems as presented. Can I get a second?
Second.
Any other comments or questions for consideration? All in favor? Aye.
Aye.
We have all board members in attendance voting an aye.
Great, thank you. So motion carries. Next, I'll make a motion to approve not to exceed amount of 1.5 million for FY 2025 for AWS Web Services subscription with federal participation amount of 990,000 and state participation amount of 510,000 as presented. Can I get a motion?
So moved.
Dana and Singh, thank you. All in favor? Any questions or comments? Okay, all in favor? Aye.
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 All members voted yes in attendance.
Okay, thank you. Motion carries. Thank you, Venkat. Thank you, Tracy.
Thank you.
So last but not least, we're going to hear some policy items related to the 2026 plan certification standards and the federal conformity regulations. Becca, are you on?
Hello, yes, I am. Okay, thank you very much. I'm Becca. I'm the Senior Health Policy Analyst at MHBE. And today, I guess you can advance a slide or two. Today, I'll be giving you a preview of the draft value plan designs for plan year 2026 that our value plan work group recently voted unanimously to recommend. And let's see. Okay, yes, so on the first slide here, so this is all we have for plan certification standards. This year is the value plan designs. The designs might need some adjustments to comply with the actuarial value calculator that's coming out later this year. And thank you to Nicole for introducing the concept of actuarial value. It is just a federal restriction on plan generosity, but we don't have the tool to measure that. and check our compliance until later this year. So that's why this presentation is a preview. And we'll come back to the board once we have been able to tweak the designs a little bit. So on the next slide, please. Just for a little bit of background on plan certification standards, each year MHBE has the authority to set certification standards for the plans sold on the exchange. So these can be, so we have the authority to, but we don't always have an item to bring, but the value plans, since we make changes pretty much annually, those tend to be a given. So the standards can be related to the plan certification standards, that is, can be any kind of anything related to plan design, to operations, other requirements. So I've listed a few on the slide here, just to illustrate the range of things that the plan certification standards may be, and that the value plans are one of many plan certification standards that we've introduced over the years. So we use the value plans as kind of a policy tool to work towards several goals. So as always, we're concerned about affordability and access to care. And so the value plans prioritize pre-deductible coverage. It's one of their features. And so that helps people access care before they've hit deductibles that are getting higher and higher by the year. So the standardized designs as well are intended to make it easier for consumers to choose between plans and make apples to apples comparisons in a way that's tough to do with other non-standardized plans. And then another goal for the value plans is to promote health equity. So one of the things we've done is made diabetes care free to diabetic enrollees in the value plans. Next slide, please. So this slide just shows that value plans have evolved a lot over the past few years. So if you're interested, you can read more about that on this slide. But the main takeaway here is just that the main change over the past few years has been to standardize the value plans, which means that there's just more requirements, and they're all the same. The value plan designs are the same across all the carriers, as Michelle and Brad were mentioning during Brad's presentation. And so the changes that we've made to these plans over the past few years have been driven by our work groups. And the work groups always consist of a broad range of stakeholders. We have consumer assistance workers on there. We have consumer advocates, carriers, providers, state agency representatives, all kinds of folks to weigh in on these changes. So the most recent group met 6 times over this summer, and we'll reconvene that group now annually to discuss the standardized value plan standards so that they can recommend any updates on an annual basis. So that's where these recommendations are coming from. On this next slide, please. This is a summary of the updates that the most recent work group voted unanimously to recommend for 2026. So the designs are the same as they were for 2025, except for a couple of key changes. The first is a reduction in lab copays in the plans in which we were able to make it work with the actuarial value. Some of the plans we were hitting the limit for generosity, but we were able to bring it down from $80 to $45 in a couple of the silver designs, and then to $55 in the bronze. And then the reason we chose to do this was because of that principle of health equity promotion. Lab copays can be, the expensive labs can be a lot for people with multiple chronic conditions or comorbidities, and often the conditions that people have that are chronic or comorbid, they are often they disproportionately impact people of color. And then the second change that we made is to align the pediatric dental coinsurance amounts. And this is more of a technical change, but we were unusual among states in having the major services category split up into 2 different classes with separate cost sharing. You can see the comparison. We used to have like some major services were 20% and some were 50%. And that's just not like an industry standard. Also, we had that 20 and 50 split at all of the metal level designs instead of changing it based on the level of generosity of the plan. So what we did is for this new aligned approach, we we made the cost sharing lower for plans where people are likely to have lower incomes if they're enrolled in those plans, and then increased it for the plans that people with higher incomes are enrolled in. So that's 20% for the most generous silver CSR, and then higher for the gold and bronze plans, etc. You can just see that on the slide there. So those are the two changes, and yeah, as I mentioned, that all the other elements remain unchanged from the 2025 designs. Next slide, please. So here's the timeline for this work. We recently presented these updates to the Standing Advisory Committee for review. And then, like I mentioned, we're waiting on the actuarial value calculator. But you know, once that comes out and we've made some adjustments, we'll bring the designs back to the board, have a public comment period, and then have this board vote on the final versions in probably February. And so that's why this is just a preview today, and we're not asking for action on this. It's just to give you an idea of what's in the works, because you know, this is a time of year we would be talking about plan certification standards, and we want to keep you in the loop. So thank you. That's all I have on this part of the presentation. I could take any questions on value plans or plan certification standards at this time.
Any questions for Becca?
Question. So when do you think we will know how much it's going to cost us? Sometimes in fall?
So what happens in the fall is the actuarial value calculator comes out, and so that it doesn't have to do with cost necessarily. It just tells us whether the plan designs that we've made are too generous or not, based on their federal restrictions on how generous the plans can be. And so if the designs that we've come up with are too generous based on the federal restrictions for the upcoming year, then we'd have to go back and probably increase some copays or something like that to make it to make sure that we are in compliance with the federal restrictions, which
how can we make a decision without knowing how much more financial burden we're going to place on the state?
There isn't an associated burden to the state. It's just how the plans are designed, and this is for 2026, and so the rates for 2025 don't impact this. So this is all kind of far in the future, and when we'll have plenty of time to think about all those things. Does that answer your question?
And I could add a little bit more, Singh. So the carriers have to submit their rates for plan year 26 by May of 2025. And in order for them to determine what they're going to charge for their premiums, they need to know what are the benefit designs. So what are we requiring them to cover in the value benefits? And we have to work within the parameters, what we saw earlier, where I said on the gold plan covers 80%, the carrier pays 80%, the consumer would pay the 20%. That's that actuarial value. And we have to wait till the federal government comes out with that calculator. Typically that we'd like it out now, but they have had some challenges in the past where they're not getting it out till January. I've heard that they're going to try and get out before the end of this year. And so then after they do that, we go back and look at everything we've done to this point in time and say, do we still fit within those parameters? And if not, then we'd have to go back and say, all right, do we need to tweak that, like the lab and here, the lab copay, we decrease it from 80 down to 55. Does it need to come back up to 60? So those are it's the balloon that we can only squeeze so much.
Okay, I mean, I'll wait when we see it next time. My concern will be, you know, through any of the combinations to know if state is going to be burdened with additional funding of any type. That will be my, focus.
There will not be any additional funding on the state. It will just determine how much the carrier has to pay for services versus how much the consumer has to pay for the services. Doesn't have anything to do with state funding.
Okay.
Thank you, Becca. Thank you, Singh. Becca, do you want to continue?
Great, thank you, Secretary. Yes, so the second item that I have for you today has to do with regulatory updates. So this package of updates that I'll be discussing are to conform with federal regulations. So the updates in this package are listed on this slide here. You can refer to the memo for more background on each of these if you like, but basically we are proposing to clarify the effective date for a change to the failure to file and reconcile policy, proposing to eliminate the 15th of the month rule for special enrollment periods, removing the expected contribution requirement on the 150% FPL special enrollment period, allowing retroactive termination of private plans when people enroll in a Medicare Part A or B plan with a retroactive effective date, and then also making a technical update to remove some redundancies to this particular section of COMAR listed on the slide. Next slide, please. After today's meeting, if the board approves, we will be submitting the updates as usual to the Joint Committee on Administrative, Executive, and Legislative Review, and also to the Maryland Register for publication. And then again, as always, there will be a 30-day public comment period, and we'll be bringing it back to the board in January for a final vote. I can take any questions on this item at this time.
Any questions? So I move, if I can get a motion to move to approve the proposed regulations and authorize MHBE to submit the proposed regulations as presented to the Joint Committee on Administrative, Executive, and Legislative Review for review and to the Department of Legislative Services for publication in the Maryland Register. Can I get a motion?
So moved.
Thank you, Dana. Second?
I'll second.
Thank you. Any questions or comments? Okay, all in favor? Aye.
Aye.
Abstain.
And Aika, I'm not sure if your hand was raised or not. Could you confirm?
No, I was gonna also abstain as well, but Sig beat me to.
So can we talk about why you both want to abstain?
My thoughts are kind of similar to Singh's. I know the clarification between the cost sharing versus what the consumer and the carrier will pay. So I think having a bit more clarity, I understand the timeline and we're waiting for that information to come out would be helpful. But that's why I just abstained particularly at this time.
Well, so this is back to the cleanup language related to the federal regulations. We're not talking about the first issue anymore. We're talking about the second issue. So Becca, do you want to go back, or can we go back to the slides that you talked about what's different from the Federal Register? Yep, this one.
Sure.
So that's what we're voting on now.
And just for clarity, there was no vote needed on that first
Exactly.
item.
That was
Okay.
just informational. Exactly.
Okay, this is helpful. I crossed those two together. Let me just
They're
take another
just-
look at the slide. Yeah, thank you.
Sure. Singh, what about you?
Same as mentioned. So let me read the slide again.
Okay. We'll just wait, give them a minute. And Becca's clearly still here to answer any questions you have about updating the regs to conform with the federal regulations.
So whenever we go back to motion, I'll read
Yeah.
that again.
So I'm going to make the motion again. I move to approve the proposed regulations and authorize MHBE to submit the proposed regulations as presented to the Joint Committee on Administrative, Executive, and Legislative Review for review and to the Department of Legislative Services for publication in the Maryland Register. Can I get a motion to approve?
Clarification. So are we authorizing that this also be published, or this is only for
So
review before?
can you go back a slide, please? So this
can
is the
talk here and-
regulatory framework that we always go through for everyone, not just the board, but this is the regulatory framework. So when you submit to AELR for review, it has to be published for 30-day public comments. So you can't put out regs without giving opportunity for people to weigh in on those. So we'll get a formal vote for final action on the 21st. But the publication is so people, the public, can see what the proposed changes are, and they can comment if they, have a desire to comment. Does that help?
So in a way, we are still proceeding with, with what has been proposed over here by publishing. And once we start getting comments from everyone to that 30-day notice period, we're in a way proceeding with that.
No, what's happening is we're trying to match, and Becca, if you want to say this, you can say it instead of me saying it, but I'm just talking in general now. We're trying to bring in line our current regulations with the proposed changes from the federal government, and we have to do that in regulations. And so what Becca laid out for you are the language for the proposed changes, including some cleanup language. So we have to put it out for public comment because we are changing regulations. But during that 30-day public comment period, if we get no comments, then people are okay with what's there, and we'll still bring it back to the board to formally vote, yes, do we agree with these changes? But during the 30-day public comment period, people may say, well, I don't agree with that, and offer a recommendation or some other language. And that's when we go to working with legal to make any review to the current proposed languages that she presented based on the feedback that we got. In which case we would still be having that discussion, whether or not we want to take action, a formal vote on the regulations based on either no public comment as written today, or public comment with some changes based on that public comment. But the formal vote, the final vote, is not until January. Does that help, Singh?
It does.
Thank you, Secretary. And I'll also add, so some of the federal regulatory updates are requirements for the state exchanges, so we'll have to implement them regardless. Some of them are at our option, and so that's something that it can be commented on by public during the comment period. But then anything that's at our option won't be it. So you can see the final step on the timeline is regulations effective. That's assuming if the board does vote on the final action to approve it. That's when those things that are at our option would become effective and not before, just to make that clear.
Okay, thank you.
So from a process point of view, should I make the motion again?
I don't think you
I
need
don't
to
think-
because you are in discussion.
So I
Okay.
raised my hand for yes. I re-raised my hand from abstaining to yes, I agree with the motion.
Okay, so do we have we need, or did everyone vote, or?
I think just call the vote. and
Okay.
have it-
Okay, so I'm gonna call the vote. All in favor? Aye. Aye.
All hands are raised in favor.
Thank you. So motion carries. So this will be the timeline, Singh, and for next steps.
Thank you
Okay,
all.
so that's the end of our formal agenda. We have no closed meeting. And Michelle, before I formally close the meeting, any last comments or questions?
No, just thank you all very much for your dedication and your time. We know we ask a lot of you to review, and we certainly appreciate it. Thank you.
Okay, so I'm going to formally close the September meeting, and thank you all for your participation today and for all the speakers for the great presentations. It's almost October, guys, so enjoy what's left of September.
Bye.
Bye.
You must be ready for another vacation now.
Bye.